Why do we speak about infections and why so many people becoming involved in this? These are the Italian estimates in terms of cost, number of patients, and so on. 450,000 to 700,000 a year, with a cost of over 900 million euros a year. These infections, however, can be prevented. Maria Luisa Mara made an estimate, and she says that about 1,300 people could be prevented from infections. To prevent infection, it's very important, therefore, to monitor the infection and to know one's reality. In our institute, we carry out an active form of monitoring. We carry out an incidence study of HAIs, and we've been doing so since 2003. And as of this year, we have started a prevalence study. As far as the incidence study is concerned, every patient who is admitted to a hospital has a specific card, which is filled out by the patient and tells us if they've had previous nosocomial infections and so on. We have 70% of patients with this kind of data. In January this year, we carried out a prevalence study. We went to the surgical departments on one specific day to see which patients were infected, and I will present the data of this monitoring activity. This is the percentage of our infected patients, between 5 and 8%. Perhaps I'm underestimating it a little bit. However, between 4 and 5% of the patients who come here to be treated incur an infection. Infections are those that we saw earlier on in the Italian study: pneumonia, catheter infections. 30% of our patients have a catheter, surgical site infection, and blood infections. This is the length of the hospital stay. Whoever has an infection stays in the hospital longer. This is true in our facility as well as in others. Non-infected patients are shown in the blue box. In orange, you can see the patients who have had an infection, and perhaps they're weaker, more severe patients who would stay longer. However, they have a hospital stay which is 6 times as long as those who do not have infection, constantly between 2007 and 2007. In the prevalence study, we went to see which patients were infected in the surgical wards. There were only 70 patients. However, 20% of these patients had been operated on in the 24 hours prior to the interview, and 27% had infections of the surgical site, pneumonia, or urinary tract. The number of patients undergoing an antibiotic therapy was 76%. What are the germs that are involved in these infections in our hospital? I have brought some examples to show you here. The surgical site, the most important germ is Staphylococcus aureus. We then have Enterococcus, Escherichia coli, Pseudomonas aeruginosa, and Candida. These are data that can be found in a number of studies worldwide. Blood infections, we said that our patients have catheters, and on which there are colonies of germs, especially those that we have on our Staphylococcus epidermis, which is regularly on our skin. And many of our patients have blood diseases due to gram-positive germs, especially Staphylococcus epidermis. Why is it important to have a good knowledge of one's own facility and to know which bacteria and which form of resistance there is? What does this mean? It means which antibiotics I can use and which I cannot use. to fight these infections. This is an American study in which the resistance of these germs was compared between 1998 and 2002. You see the gray bars compared to resistance in 2003, and you can see that in 2003, resistance of these germs, Enterococcus, Staphylococcus aureus, cocculase negative staphylococci, you see that the level of resistance changes in the course of time.
Quindi le resistenze cambiano nel tempo, in genere purtroppo aumentano.
A couple of examples. These are some of the main bacteria that are causes of infection. Staphylococcus aureus, the problem of which is that it is resistant to methicillin. When you see MRSA, it means methicillin resistant. And this is a resistance marker, which is very important, because if you have an MRSA, it means that the doctor has very few weapons to use, very few antibiotics. This is a germ which is extremely pathogenic and causes very severe infections. The other problem regards the Enterococci, which is vancomycin resistant, VRE. Here too it is resistant to almost all antibiotics that are on the market today. We'll also speak about the gram-negatives and the fungi. This is a European monitoring system which is called EARSS. These are the countries that are taking part in the study, collecting resistance data for various pathogens, Staphylococci, Enterococci, and those that I have already mentioned. And I have shown you a table with a proportion of MRSA. It's very important because it's the methicillin-resistant Staphylococcus aureus. You can see this is a kind of traffic light. The green light, it means that it's very good. We have very few MRSAs. In yellow, so-and-so, and in red, unfortunately, we see that there is 35 to 50% of resistance, meaning that the Staphylococci are pretty tough. You can see that in the Nordic countries, colored in green. There are many reasons. One of the policies that they implement there is search and destroy. In other words, they practically identify in all the people who enter the hospital, whether you're patients, employees, or whatever, you're controlled to see whether you are a bearer of Staphylococcus aureus, because we can all have this germ on our skin without it being a particular problem. So anyone who is a bearer of this MRSA germ is reclaimed, as we say, subjected to antibiotic therapy or kept in isolation until they have been cleansed, so to say. However, they have acquired a level of MRSA which is very low indeed. Our institute last year had 33%, which is within the average. This is the history of our facility between 2005 and 2009. We had a lower level of MRSA, and then in 2007 we reached the Italian average. While this is the in blue, you can see Staphylococci in blood, sepsis, for example, while the others are Staphylococci in the other materials, surgical site wounds and infections, or in pneumonia, and so on. And this is the EARRS figures. We had a low percentage, whereas now we have reached the average Italian data. Why is it important to know one's reality? Not simply because my hospital is not different from another, but these are the wards. Speaking of MRSA, the data between 2005 and 2009, the hospice patients are certainly different from the children in pediatrics. All of the Staphylococci that we find here are methicillin resistant, but not in pediatrics. Every ward is different from another with different patients, so probably there are different antibiotic policies. Another important germ that I was telling you about the Enterococcus resistant to penicillin. 2008, we had a problem, a small epidemic, with the patient coming from another hospital, and he brought this germ with him. Unfortunately, it spread very fast because it's a germ that survives very well in the environment. And from then on, we started our surveillance system, and we now do what we did in Northern Europe. We monitor all the patients who are entering the hospital to see whether they have this Enterococcus. And I must say that there has been some success, because since starting surveillance 2008, we did not find this Enterococci in blood, and neither have we found it in other materials. Gram-negative infections are also important, and the resistance of Echinococcus to ciprofloxacin, which is an antibiotic which is very frequently administered. You can see that urology and hematology use this antibiotic very frequently, and almost all the Escherichia coli that we see are resistant to ciprofloxacin. So without even waiting for the antibiogram, because it takes a couple of days to see that, the doctor decides that probably ciprofloxacin perhaps is not the right thing to use. Pseudomonas aeruginosa is another type of bacteria, and these two are very sensitive to therapy. If I use ceftazimine, amikacin, or carbapenems, I will find bacteria that are more and more resistant to these these antibiotics that I use. And my last data regard the fungi. In Lombardy, we have a surveillance program called Sentilom, which allows us to compare our situation with that of other hospitals. We're speaking about rates here on the number of hospitalized people. This is the average of the hospitals in Lombardy between 2005 2008. In our facility, we have a rate which is 3 times higher, and we have different types of patients, and Candida, unfortunately, more frequently than in other hospitals, lead to bloodstream infections. And Candida albicans is the most common infection in this sense. I would like to end here. I've given you a picture of our situation here in Italy and in our facility.